I'm Scott Smith. I'm a professor of social work at Oakland University and also a consultant here at Wayne State University School of Social Work in the Center for Behavioral Health and Justice. And today we're going to be talking about suicide, but more specifically looking at how we can increase our confidence around making the hard calls, knowing what to do with our clients who are experiencing some type of suicidal behavior, whether it be thoughts or goes all the way up to like starting to plan it out. We're gonna take a closer look at actually, what we can be doing and looking for to both make an assessment that protects our clients and also protects ourselves. So we're grateful you're able to join us today. It's a core requirement for our ongoing licensure. If we feel like we need to be equipped to handle individuals managing pain issues, to individuals who may be the victims of trafficking, do we also not think that suicide is equally important and maybe arguably a little bit more likely to come across our path than some of these other issues? So I'm a bit salty about that, I'll admit. I think we've dropped the ball on this. As a professor of social work, I can tell you that I would like to see this become a core competency for all MSW graduates. I hear individuals with, MSWs frequently say, yeah, I don't feel like I really got, good enough training before I left school and being able to do this. And your results may have been different, but that should not be something that anybody says. You should be able to leave your graduate program, with the MSW confident in your ability to perform this task. Now, I say confident, not feeling great. And I want to really stress this. I can't help you feel really good about the decisions you'll make when you're assessing a suicidal client. I can't help you because I can't do that for myself. I've sometimes worked evening shifts at the ER, come home at 2 a.m. and lied awake for 2 hours thinking, did I do the right thing? Is that person going to be okay? Second guessing myself. Why? Well, the same reason that I'm assuming all of you are here today and all of you are in this field is because we care about our clients, the people we work with. And we take very seriously the responsibility that we have. So Michigan, it's a problem. Are there solutions? Trainings like this, I think, are a great start, and I'd love to see this become something that gets equal weight with the other trainings we're required to do for our license. Now, as suicide has grown, it's actually started to replace other leading causes of death, and this is, as I gave you the example of automobile accidents, suicide has crept up there. When we look across all ages, suicide is now the 10th leading cause of death. And why that, should alert us to, the scope of the problem is that many of the other forms of death are conditions that we are still fervently working to make progress on, to better understand and try to treat. Conditions, both chronic illnesses, debilitating illnesses that we're making strides on, but we have some pretty significant limitations. Well, not all suicides are avoidable. I don't believe that. I think far more are avoidable than clearly are being avoided. And when we get into some details about what's been the same, what's changed, we can start to see certain trends that hopefully will not just leave us feeling kind of overwhelmed by the scope of the problem, but hopefully give us a sense of confidence that, we can actually see this trend changing, and it's changing for some fairly recognizable reasons. That's good news, right? Like anytime we can kind of see a pattern that's signaling a shift, that gives us a targeted intervention. So that's good news, even though this is not the most upbeat, uplifting topic to spend your Thursday afternoon covering. Now, one of the bigger changes that has happened and has potentially substantially influenced the overall number of deaths from suicide is a more recent phenomenon, and that is opiates are found or present in 20% of all suicides. And this actually is a trend we've observed since around 2016, 2017. The data I'm going to be sharing with you today is the most current data, solid data that we have, and it's mostly from 2019 and 2018. So there was this thing in 2020 you might have heard about called coronavirus. And so kind of as a disclaimer, I don't know what 2020 is going to look like when we see it in data, but I'm assuming it's going to be the giant flaming mess that we all lived through. So just be prepared that, you know, potentially everything I'm talking about today in terms of trends and that could just fall completely apart when we see what actually went down during 2020 and the pandemic. What I will say is this, that the trends are significant more because of what it reveals about risk factors and protective factors. And I'll define those terms more in a minute. So let's look at suicide over the last decade in relationship to homicide. If you turn on the news or look at your news feed at any given day, it's easy to get the impression that, you know, we are just devouring ourselves, that we are a country filled of homicidal maniacs that just can't wait to find new and better ways to kill each other. And in fact, when we ask most people, what's happening with the homicide rate in our country? Do we see it going up? Do we see it going down? And there's an overwhelming, emphatic, it's increasing. It's getting out of control. Turns out it's been relatively stable, right? Over the last 10 years, it's been relatively stable. If we go back even further, we go back to 1980, what we see is that the overall trend has been a decrease in homicide. Now, conversely, suicide has been, you know, steadily rising. And what's interesting is a lot of the explanation that's been given for why homicide rates have stabilized is that we've developed better interventions in the field for treating injuries, gunshot injuries, exsanguinating injuries, that is bleeding injuries. Like, we can do more in the field, more people's lives are being saved by first responders, by emergency room professionals. And there's a degree of truth to that as well, but those same things can apply to suicide. What do you think is the biggest difference? And this is where you can feel free to unmute yourself or throw something in the chat, but I don't want to just talk to the screen. I want to talk with you. So why, if we have, you know, additional means to, you know, save lives that, you know, could be lost due to homicide or due to an act that could result in a homicide, why is that not holding true for suicide? Why is that rate continue to increase? What's the big difference there? Okay, so drug usage, right? Social media, we'll elaborate that. Okay, I see guns there. The means, the type of injury that can play a role. Stigma. There, love that one. Suicide often happens alone. That becomes one of the biggest differences, right? In a homicide, presumably there's at least one other person around. Sadly, suicide is something that happens in isolation. And again, great, like the other issues, the isolation, the fact that, you know, oftentimes one of the bigger risk factors for suicide is the existence of a mental illness, often a serious mental illness that can result in social alienation, receiving stigma and having people reject you, or your symptoms become sometimes too much and your family can't support it. But we're going to see just how powerful that idea of isolation is when we look at suicides and who and where it's affecting individuals. No intervention when you decide to go through with it. That's a good point. You know, the reality is when somebody has determined that they're going to do this, very rarely do we have the opportunity to intervene. The people that I assess in the ER overwhelmingly are individuals who at least acknowledged that they wanted help or they were having these thoughts, right? A portion of them are individuals who made an attempt and survived it. But overwhelmingly, they're individuals who articulated it. And if I were honest, in 20 years of doing this, I would say there's only a couple of times that I felt like their individual was doing their best to not reveal anything. And I followed a hunch and was able to intervene in somebody who otherwise was going to complete and not let anybody in on their plan. And it was actually a 16-year-old. This was when I was living in Arizona. I was doing mobile crisis work at the time, and I got a call from these really strange parents that I rarely interact with. They were very deeply concerned parents who were willing to accept that their child might not be perfect or might actually be at risk for certain things, right? Like most parents, that's not their strong point, being able to really imagine and accept that their child could have problems. And these parents were. And when I got there with my partner, our mobile team was a team, we worked in pairs. The parents said, I appreciate you coming out. I just want to preface this by saying we might be making something out of nothing. And I said, hey, we're glad to help. What's going on that's concerning you? And they described how their son had been very depressed, and that had been going on for a couple of years. Depression runs in the family. Both mom and dad had it on their side of the family and had struggled with it themselves, so they were a little bit more tuned into it. And then they said about 2 months ago, he out of the blue just seemed to get better and seemed to be doing well. And they talked about how he had become Buddhist, but they just had this nagging feeling that something was off, and it was getting to the point where they felt like they were thinking about it too much to not do something. So they did something. They called the crisis line, and I was able to respond. And when I went up to this young man's room to talk to him, his room was not what you expect of an adolescent. Most of his belongings were boxed up, packed away. There weren't posters or pieces of art or anything in the walls. And he was sitting on the bed, and he was very pleasant, very polite. And I just started talking to him, and I just put it right out there. I said, hey, so I'm here because your parents are concerned about you. And I said, do you understand that? Like, have they talked to you about their concern? And he's, incredibly polite. He said, absolutely. He's like, I really had struggled with depression, and things just didn't seem to be helping, but, I've been doing better lately. I've, found some solace in Buddhism, and that's really helped me just kind of put things together. And I'm like, well, I'm encouraged to hear that, right? We'll talk about religiosity and how that serves as a protective factor in certain instances a little bit later today. And so I said, well, so tell me what's kind of been going on recently. And, he was fairly generic. He's like, oh, things are just pretty normal. And I said, okay, well, why do you think you turned the corner so quickly? Like, what about Buddhism, helped you? I was trying to identify, like, was it the practices? Was it the shift in your orientation? What was going on? And he had difficulty articulating anything there. So then I started to ask about like his room. I said, your room seems especially large with, all of your belongings kind of boxed up and put away and nothing on the walls. And he laughed and he's like, well, part of my Buddhist, philosophy is that I don't want to be encumbered by things. So I've been donating things, giving things away. And I'm like, that's a brilliant answer, which is either true or you're getting your affairs in order. And I don't know. Like I'm kind of feeling a little bit angsty, right? Like this is kind of confusing. So we started just kind of talking more about school and what he liked, what was going well at school. Again, not much depth there. And then I shifted into what I think is one of the best indicators of suicide risk, and that's future orientation. So I said, so, we're getting closer to summer. Do you have any plans coming up for the summer? And no, I haven't really, thought about much. I'm like, oh, okay. Well, next weekend there's a holiday. I think we're getting close to Memorial Day. I'm like, do you have any plans then? no, not really. Like, I'm like, no, what do you got going on tonight? I don't know. I'll figure something out. So now in my mind, I don't see any future orientation. And I could interpret his, giving away items as a spiritual journey, or I could interpret it as getting his affairs in order. He's not presenting as depressed. He's telling me he's gotten better. If he was an adult saying I'm fine and everything, I wouldn't have had the criteria to involuntarily get him treatment. But there was something there. And one of the things that was most influential to me was the fact that his parents, who are far more the expert on their child than I am with my 30 minutes of experience with them, they felt uncomfortable. That combined with the lack of future orientation, or at least the articulation of a future orientation, the lack of clarity on why he was feeling better, led me to believe that he was fibbing to me. He wasn't being straight. I got the sense that something was off. So I went back, talked to his parents, and said, I think we have to go with your instincts on this. I think we need to actually look at a higher level of care, because he's got things a little too together. And they're like, yeah, let's do that. I hate the thought of having to go that route, but we just don't feel good about it. I said, okay, well, I'm going to go back and tell him. So I go back in his room and tell this, Buddhist, remember, presumably nonviolent, 16-year-old, that, hey, I'm not calling you a liar, but here's what I'm worried is going on. I'm worried that you've made the decision to end your life. And that decision has allowed you to kind of see an end to the pain that you've been fighting through for so long. And because of that, you appear better to people, but I don't think you are better. I think you want to die. And I'm recommending that your parents take you to the hospital. And he switched immediately and lunged at me and started swinging. And at least it was confirmation. I'm like, all right, so yeah, called it, right? Like I was right. And that was, again, not something you want to be right about, but that was validating. Now, within that experience, what has always stuck with me is that he's part of what we've often referred to, and we'll look at this number again in a little while, as the 25%. That is, the individuals who end up completing suicide who supposedly gave no warning signs. Now, I'm not necessarily convinced that the number is as high as 25%, but one of the biggest problems, and we see it in that example, is that many individuals, once they make that decision, they have this sense of confidence that like they're almost done with their suffering, that the pain is almost over. And because of that, they actually appear to be doing better. They have an end in sight. And that's why family members are often shocked, because it seemed like their loved one was doing so much better, and then this seemingly came out of nowhere. The good news for us as clinicians is that I think it is much easier to spot some of the warning signs, especially as outsiders, right? Because we always have a blindness to things going on within ourselves, within our families, right? Those closest to us. Now, as we start talking about this process of assessment, it's important that we differentiate assessment from prediction, because unfortunately, a lot of times when I hear discussions around, we need to do better screening for suicide, we need to use different screening tools, most of the screening tools actually rely on predictive values. That is saying, here are risk factors associated with suicide. What is it that, this individual is expressing? And we're going to use that to determine whether or not they're going to make a suicide attempt. And the problem is that the risk factors don't have a very neat translation into suicidal behavior, right? Just because somebody has a risk factor does not mean that they're actually going to make a suicide attempt. As problematic as suicide is, it is still, relatively speaking, a pretty rare event, at least on a population level. So it's not very easy to reliably predict somebody's suicide risk. And what I'll go a step further and say, to predict their suicide risk in the short term. Right now, we might be able to look and say, based on all these factors, this individual at some point in their life is most likely going to at least make an attempt. But that's not what, as clinicians, we're most interested in. We're interested in that individual and what's going on right now and what we need to do to intervene, right? Now, as we use these more prediction-based algorithms, what we end up doing is basically coming up with screens that dramatically over-identify somebody's risk, and it kicks off a process that can actually do more harm than good. So there's a lot of agencies, practices that have the policy that if somebody expresses suicidal thoughts, that they have to go to the hospital. And I get on one hand why we would have that policy. And what I'll tell you is I think that it's a policy that focuses a little too much on protecting us and not so much on the client. And I think there are better ways to protect ourselves and certainly better things we can do for our client. Those of you who have never worked in a hospital or been through the hospital process might be prone to kind of assume that if somebody goes to the emergency room because they're having suicidal ideations, that they're going to have access to certain things, like they'll definitely be able to see a psychiatrist. The truth is, not so much. In fact, that's not, typically part of the services available in the emergency department. You might also assume that though they'll wait because it's an ER, that they'll be seen and processed relatively quickly. What I can tell you, and again, Beaumont Royal Oak is one of the busiest ERs in the country, definitely the busiest in the state. And even before coronavirus and before staffing changes and things, it was still common for people to wait 24, 48 hours even to be seen, just because the volume is so high. And what's going to happen is you're going to be taken into an area, placed with other individuals, cohorted with individuals who also are having psychiatric problems. And if their symptoms are worse than yours, is that going to be a very pleasant therapeutic place to be? Definitely not. You're going to have to go through a complete medical evaluation because medical clearance is required if we have to look at a higher level of care. And what I have seen, in the years I've worked in emergency departments, both here and elsewhere, is that when people get sent to the ER, it too often is done as this is out of my comfort level and I want somebody else to handle this, to make the call. And there's not a regard given to what is this going to do to the patient, especially in the future. And let's start that conversation by thinking about what happens for an adolescent. We've been asking adolescents to, share, to say something when they're feeling badly. Well, what happens if an adolescent admits that they've had suicidal thoughts to school personnel? What do you think? Feel free, again, shout it out, chat it out. What's going to happen? Okay. Yeah, they're going to get sent. Parents are notified. They have to go to the ER, get out of here. It starts to feel kind of like you're being punished. In fact, if there's one thing I hear more than anything else, it's that. It's like, I was honest. I did what people asked me to do, and I got punished. I got sent to the ER, and I sat here for days on end. And add to that, now there's going to be stigma associated. There's going to potentially be like even a shaming process, as Adrian points out. You can't come back to the school until you're no longer a danger. So we're going to take away your social supports because you're suicidal. That's a brilliant idea, right? Like, these are scary practices. And again, I don't know how schools arrived at these decisions, but this is a serious problem. And ultimately, when they end up in that emergency department and they're feeling like this is what they get for being honest, what do we expect is going to happen in the future when they're having these thoughts? Do we expect them to share them again? Or do we think that they're going to learn from this experience and keep their mouth shut? And that should terrify us. A policy like that should absolutely horrify us because it's discouraging people from doing the things that we want them to do so we can help. Now, what about when somebody goes to a therapist? I've had many occasions where a therapist has sent their patient in because they said they were having suicidal thoughts and that's their policy. And, my frustration with that is that, you've taken somebody that you should know very well and put them in an environment to be assessed by somebody who doesn't know them at all. Right. So I'm going to be limited in what I can discern or interpret based on, a very small glimpse into this person's life. Was that in the client's best interest? Is that guaranteeing them the best care? Like as just a practice, as a reflex, it's problematic. Now, as a second opinion, I'm not sure, I'm seeing a lot going on. I need, some additional assistance. I love when a therapist will actually call and ask to speak to me and say, hey, I'm sending so-and-so in. Here's what's going on. Here's where I'm at, what I'm thinking. And, I'm looking for some more help. Great. Let's be a team. Let's knock this out together. That's great. But otherwise, your client ends up saying things like, I feel like once I got too messy or complicated, that my therapist wanted to get rid of me. You were suicidal before, and now your therapist thinks you're too much? Like, talk about piling on, right? And when I've talked to therapists, about this and heard them say, like, listen, I don't feel confident to make that call. Like, if I make the wrong call, then that person dies. And I'm like, yeah, welcome to the NFL. We're professionals here. Like, this is the job. And believe me, it doesn't feel better for me. I'm not any, less, uncomfortable with this than you are. But again, if we think and put the client first, what is in their best interest, right? And it's rarely to have this over identification and hit the panic alarm, right? If we're going to do any type of prediction work, use the screenings, and some are better than others, they should be a guide to know when do we need to go deeper? When do we now need to do follow-up and ask additional questions? Not just say, all right, off to the hospital, off to, even sending somebody to an inpatient setting without doing more of a considered assessment. And the effects of that experience aren't just with your current provider, it's with all providers, right? Like, how many times have you heard a client say, I don't trust therapists because blank? So they have one experience and that is colored their impression of the entire field. Right? And they share that with their friends. That becomes a discouragement to people who would otherwise seek help. This table that I just pulled up, this actually comes from, an excellent article, came out in 2012. The author was looking at how well certain risk factors actually correlated to not only their ability to predict suicidal behavior, but how often they generated a false positive result. Now, look at the first one, past suicide attempts. What we know is that it is a consistent predictor for future attempts, and also for completed, suicides. However, not everybody, in fact, a small portion of individuals who make a suicide attempt go on to ever make a subsequent attempt. Now, the fact that both of those things are true is what helps us kind of orient to this difference between the prediction of suicide using, these variables and statistics and actually conducting a more thorough assessment, right? And again, this chart goes on, you'll have access to these notes, and feel free to review them in detail later. I know we've got a short amount of time together, and I want to make sure we get to everything. And thank you for answering some of the questions about how would you connect with the emergency room. If you call the hospital where you sent your patient in and ask for the psychiatric social worker for that team, they'll put you through. I can't guarantee in every hospital like how easily accessible that will be, but that's a standard practice, and actually one I can tell you we welcome, and everybody I know that does that type of work really welcomes. We want that feedback. We want additional information. What we want to do is not try to predict suicide, but actually assess suicide. In this context, we're referring to a clinical judgment of risk in the very near future. Because when we're talking about somebody who's in a suicidal state, we're saying that they're in crisis. And by definition, that is a short-term state. When we use the actual clinical definition of crisis, which is an exhaustion of your capacity to cope, right? You no longer have the ability to cope with the demands placed on you, so you're in crisis. And by definition now, you're potentially suicidal and or homicidal. And just as an aside, one thing to keep in mind is that we've drawn this arbitrary line between suicidal and homicidal behavior. But when somebody is in a suicidal state, they can, without the goal of harming others, often be quite dangerous to others. Kind of put this in the context, one of the most common suicide plans I hear from individuals is they plan to drive their car into oncoming traffic. And when I ask them, so what about the people in the car you hit? What about the potential to have hurt them or killed them? Without fail, they all look at me and have this sudden like awareness moment. They're shocked, they're horrified, and they admit, I didn't even think about that. It's not because they're not good people. It's not because they don't care about others. It's because in that crisis state, they become literally unable to see beyond themselves, right? The pain, the hopelessness, the helplessness are so great that they just can't consider other things, right? So as the clinician, it's always important to remember that, the risk of harm with somebody who is acutely suicidal is potentially present. It's, again, not the same as other types of homicidal behavior by any means, but these are definitely situations where worker safety needs to continue to be important. Now, 0 to 24 hours. Why is that significant? Because it's a short-term state. Just because somebody had suicidal thoughts a week ago does not mean that they're still suicidal, nor that they need an advanced kind of intervention at this point. And the reason is that whatever had kind of exceeded their capacity to cope had either been resolved or they found a way through it. As unsophisticated as it may be, when I was doing mobile crisis teams, the number one intervention, the thing that was able to help somebody go from wanting to imminently end their life to feeling like they were going to be okay, at least for the next day or two, was helping them get cigarettes. Now, why? Why was helping them get cigarettes? They ran out of cigarettes, they're suicidal. Why was helping them get cigarettes so powerful in terms of like reducing the risk and actually avoiding hospitalization? And yes, Amy, hi, nice to see you. The slides will be available to everybody. So again, the question, why was helping them get cigarettes calms the situation? It's a coping strategy, precisely, right? An unhealthy coping strategy is better than no coping strategy. And when somebody's in a situation with no coping strategies, they're in trouble. They're in trouble. Getting the cigarettes. Do I want them to smoke? Do I think it's good for them? Do I not trust the Surgeon General warning? Like, no, I know that that's what they have for a coping skill. And in the course of clinical treatment, then when we're helping somebody adopt new coping skills, we don't get rid of, a coping skill until there's a suitable replacement, right? I often hear, clinicians, especially newer clinicians, say things like, you really need to stop smoking. You should try journaling instead. And I'm like, oh, honey, let me tell you how not comparable those two things are. Okay. Like, if somebody is smoking and that's working for them, they're not going to be journaling and be like, oh, I needed that. Like, I'm sorry. Now, I'm hoping that at some point they will have a repertoire. They'll have a toolbox full of strategies that they can use that will help them live a healthier life. But to replace smoking, that's gonna take a bit. So in that moment, getting them back to having a coping skill, because in terms of not having good choices, of our bad choices, this is the best of them. So taking them to get cigarettes, now they were good. They were going to be good, and at least until they ran out of cigarettes again. They'd be good long enough to get them in contact with outpatient providers, right? To do other things so that we can avoid an unnecessary hospitalization. That 0 to 24 is so critical. And what we're looking for are things that have been established as risk, but also as protective factors. And this, depending on when you went through school, this is a bit newer of an approach. We used to talk about resiliency, kind of like we talked about, unicorns and Greek mythology. It's like, ooh, this magical thing that exists that some people kind of have and other people don't. It's good to have it. And that really wasn't helpful unless you had resiliency. Where we've shifted now is to frame resiliency more in terms of thinking about risk versus protective factors. Risk factors increase the likelihood of something bad happening. Protective factors decrease the likelihood. And not all risk factors are created the same. Some are unmodifiable, right? You can't change race or ethnicity, but some are modifiable. You are facing housing instability. Well, that's something we can modify, and that would alter the impact that stressor was having on you. And sometimes when we can't modify very many risks, one thing we can do is actually find protective factors to put into place. And by considering this risk versus protection, balance, we can better articulate a way to help our clients, really find their own independence and be stable. And more importantly, not only will our clients be safer when we use this approach, because we're going to make better decisions about interventions and level of care, we're going to also gain additional insight and information about how our client does when things are really at their worst. But it has, at the same time, the ability to protect us. I have, and I'm knocking on all the wood I can find at the moment, I have never had a client complete suicide. Right? Now, that doesn't mean it's because I always made the right call. I'm old enough and humble enough to recognize that sometimes it's better to be, lucky than good. I've been very fortunate. But what I'm confident in is this, that when I do an assessment of somebody, I've done it in a way that should the worst happen, and should there then subsequently be an investigation into whether or not I was engaging in malpractice, I am confident that I can withstand that scrutiny. It's not a bad thing to want to consider protecting yourself. That goes along with being a professional. It's a bad thing when that comes at the expense of our clients. And that's why a good assessment is going to help us. So let's kind of look at what that assessment ultimately is going to look like, and then get into some of the numbers and get a better understanding of risk. So this model that you see here is really as close as we can come to the ideal, evidence-based approach. And it's kind of was in its original formulation from Dr. Douglas Jacobs at the Harvard School of Medicine. And then it's been, tweaked a little bit, and is known as the SAFE-T model that SAMHSA recommends. But where it starts is with that psychiatric examination. And this is the consideration of, not the suicidal behavior yet, but the person in general. Who are they? What are they currently going through? We're not going to get into, you and mom as a child, because we're in a crisis situation. We're we're looking at what's going on now. What are you facing? What are you living with? What's your current status of health, of mental health, etc. And from there, then we want to specifically be looking at what risk factors, including modifiable risk factors, do they have? What protective factors are in place in their life? And the specific suicide inquiry. That is, what are they, actually reporting to us? Are they just having thoughts, ideations? Are they having thoughts and they came up with a plan? Is that plan likely to result in their death? Do they want to die? What's their intent? Do they have future orientation? Do they see, anything worth, sticking around for? Can they get beyond themselves at all? It's those critical elements, and that ultimately taking all these things together help us, make a determination of risk and come up with an intervention. One of the things that I've heard so often, and I wouldn't be surprised if down the road we find out this is where one of the biggest payoffs comes from this approach to assessing somebody for suicide, is that it's going to take you a little while. You're going to spend 25 to 45 minutes, depending on, what's going on and what details come out, really getting in and empathizing with the client. And for so many people who are suicidal, and when they say this, it crushes you, because you realize in some ways this is a dumb problem to have, like to know there are so many people who are concerned about people, and then yet to have people who truly believe nobody cares. Like, oh, we can fix this. Like this, a lot of this we should be able to fix relatively easily because we have all the ingredients. But what they say is after that, you go through this type of assessment and really kind of dig into things, they're like, I appreciate it. I haven't felt like anybody's really spent that kind of time with me and really like cared that much. Like thank you. And as much as I appreciate the compliment, it's sad. It hurts, right? Nobody should be in that position to feel that much pain. And what we know about adult psychotherapy overall is that rapport, the quality of the relationship between the provider and the client, has way more to do with the success than the modality or our competence even in administering the modality. Like the power of that relationship is so huge. Similarly, a good assessment like this really involves you empathically getting into the messiness that too many people in their life are just overwhelmed by or uncomfortable with. And especially when we think about the stats around gender, males complete more often. Well, we'll talk about why that has something to do with means and differences in means between, males and females. And again, I'm not trying to be overly binary. I only have statistics on, binary states, unfortunately, so please don't misinterpret that as not understanding the complexity there. But, this essentially having this kind of socialization as a man that your male friends rarely know what to do with you if you're emotional. One of the other kind of things I do with all my free time is I'm a first responder. I'm a reserve police officer, and I've done that for a while. And what's always amazing to me is how, as men, we're socialized to be comfortable. Like, we can play basketball together, and if I get my sweat on you, no big deal. That's not a problem. If I get injured and I bleed on you, hey, no big deal, no problem. If I'm hurting and I cry on you, whoa, okay, hey, we're not that kind of friends. Calm down. Let's not get carried away here. Like, there's such a discomfort, and people's raw emotions really make people feel uncomfortable, especially in a Western society where we value action and doing and talking and so much. So many times what the person needs is just the presence. What they need is just to know that they're not too much. They're not too overwhelming. And doing a good assessment will actually help provide that. And then as critical to performing this is actually, documenting that you actually did these things, right? And I don't need to explain the importance of documentation, or I shouldn't have to anyway, but what I can tell you is I see examples of documentation all the time, and I'm like, Oh, you better hope that you never have to stand behind these notes, because I don't know how you will. Uh, Keep in mind that it's good to have templates you can follow for suicidal assessments. There's tons and tons of them out there that all get at the same model. This is not revolutionary. This is certainly not something I invented. What's most important is that you're able to kind of consolidate this information and articulate in a way that anybody can understand. And this will not only give you the confidence that you did the right thing, but will also help protect you in the event that somebody would accuse you of not doing the right thing. So when we talk about suicidal behavior, it's important to recognize that this is a range, a continuum, really. And it starts with that ideation, the thought, and moves to threat, which is communicating a desire to harm yourself, a gesture, which is that symbolic act. It's assumed to have low lethality, and there was no intent to kill yourself. We'll talk about the difference between a gesture and an attempt, and why that can be a little fuzzy at times in a little bit. But an attempt, by that we mean an intentional, serious effort to end one's life. And what's interesting is all that is required to turn something from a gesture to an attempt is that the individual genuinely believed it would harm them. So I've had people who came to the emergency room, they were suicidal, and their plan was to take a handful of gummy vitamins to kill themselves. When I asked them, what did you think would happen if you took a whole handful of gummy vitamins? And they said, I thought it would kill me. Okay, so you may, if you did that, that would have been an attempt. Even though gummy vitamins aren't very lethal. They're very yummy, but they're not very lethal. And similarly, I've had people who, were trying to make a gesture that didn't know that Advil and Tylenol are different and have a different amount of risk. Tylenol in relatively small quantities can be very, damaging, especially to your liver. Ibuprofen, Advil, Motrin, whatever brand name it's under. If you got enough of it congealed together in a ball in your mouth, you might choke on it, but like the dosage you would need to really do harm is dramatically different. So people's level of understanding can really vary. And unfortunately, many people have made a gesture that turned fatal, and it accidentally became an attempt. Now, the reason why it's important to kind of, keep in mind this gesture versus attempt consideration is that it becomes one of the more critical determinants when we're trying to figure out what the best way to help somebody is. And again, those of us who've been in the field longer, the whole term gesture, while it's been out there a while, really was more known as the cry for help. And in some ways, that can be a helpful concept. In other ways, it can be really kind of a negative overview of what an individual is going through, right? This is kind of saying like, oh, they're being dramatic, they're being theatrical. But as difficult as it can be to keep in mind sometimes with harder to serve clients, I guess I'll put it that way, more difficult clients, what does it mean if you feel like the only way anybody's going to pay any attention to you is if you kind of take the nuclear option, right? Like, what would we expect if you grew up in a home kind of getting to the question about childhood, experiences, trauma, and like, if you couldn't just ask for a hug, if you couldn't just get your needs met, well, they're needs, so you're going to find a way to get them met. You develop some strategies that fulfilled those needs at the time, but long term, as you became attached to them, really started having the opposite effect once you got to adulthood. In fact, that's a lot of what we see with the cluster B personality disorder, especially borderline and histrionic personality disorder. That parasuicidality is really the manifestation of, a childhood where there was no direct option to getting what you needed. If you wanted to have a need met, if you wanted to get noticed, you had to be the loudest, noise in the room. Now, kind of to the question Thea posted, that isn't a lot of suicide related to the level of childhood or recent trauma, and knowing the trauma profile could let us know more about suicide risk. The relationship between, childhood trauma and suicide risk is a little bit less clear than it's often made out to be. In fact, I won't get on too much of a rant, but our recent discovery of trauma, which is far from recent, we've known the effects that trauma, has on us in terms of our learning, even our neurological, like, performance, physiological changes within our brain as a result of trauma. That's a lot older than the quote trauma-informed movement. And too often when people like talk about being trauma informed, the depth of their knowledge about that is that trauma's bad and makes bad things happen. And it's like, okay, so good. We'll start there, and then we'll kind of go to the next step, which is trauma is ubiquitous. Virtually everybody is exposed to trauma. The question of why trauma becomes, more problematic, why symptoms develop, that's where we get into a lot of different nuances. And some of that goes into genetic vulnerabilities, differences in actual neurophysiology. Some of it goes into like the supports that were available in the aftermath of the trauma. A recent trauma is potentially a risk factor, but keep in mind that exposure to trauma doesn't necessarily send people in just one direction. Many children who are exposed to trauma, and we'll actually see a little bit of this in some of the suicide stats, there seems to be this consolation prize of psychological hardiness, that when you're exposed to more like severe early life events, one thing that very often happens is you develop more kind of distress tolerance. It takes more to really make you feel overwhelmed. And so when we look at, many of the children we most likely expect to be exposed to, traumas in childhood, we're usually talking about children who, have risk factors such as, living in an urban versus suburban or rural environment. They tend to be non-white children. They tend to live in areas that have higher levels of poverty. And yet those same individuals are among the least likely to actually complete suicide. Now, we've seen increases in those populations, but there's a hardiness there that actually, helps, like, is derived in part from like almost an inoculation to stress in many ways. And think about even secondary traumatic stress, which is something else I'm pretty passionate about and do a lot of work with. Your repeated exposure to somebody's trauma doesn't always result in you having your own traumatic response. Often it gives you something we call vicarious resilience. It gives you, the sense that you're inspired and motivated by somebody's perseverance through trouble. So trauma's a big deal, and maybe I'll be asked to talk more in depth about that in another CEU. It's an important consideration, but to say that trauma becomes a big determinant in terms of suicide risk, it's not quite that linear, that clear. So Chantalea is reminding me that we need a break. So let's go ahead and take 5-6 minutes to stretch or do whatever you need to do. Keeping in mind, if your camera's on, that we might do whatever you choose to do with you. So just note to self there, and we'll kick it back off in a couple of minutes. But I'll be sitting here, so feel free if you want during this time to ask questions either on chat or over the mic or however you want to do that. So we'll start up again at let's say 3:40.
Thank you so much.
Hi, Gina. It's good to see you too.
How's it going?
It's going well. It's going well. How have you been?
Good. I'm doing my master's at Wayne right now, so that's been pretty fun and busy.
Yeah, I'd imagine. Where's your internship?
Affirmations, LGBTQ Center.
Yeah, very nice. Are you doing outreach there? Or are you working in their like actual counseling program, or?
Yeah, I'm doing counseling programs. Actually, I did like 3 intakes this week, but every time I do intakes, I think of you. So
Blush, I'll take it. Yeah, so Claire, there's all the good suicide assessments, and if one thing I'll do in addition to making all these notes available is also give the resources from SAMHSA. SAMHSA has a bunch of these, basically it's going to go through the same assessment we're doing today, that you can use. So that'll be very, helpful to use. I'll also go a step further and say this, that I would imagine that most of you intuitively actually, understand what to be looking for. Again, there's the idea that somebody is suicidal does, really kind of increase the amount of, stress associated with performing a task. And so it's really easy to start to, mistrust your own skills. But as social workers, we have a biopsychosocial approach to understanding human behavior. And if we keep that in mind, we're going to just making sure we can answer those 3 domains, like what's going on for this individual. You'll always be surprised at how much information you just attain. Terrell, oh my gosh. I was actually thinking about you the other day. We need to connect up. So we're going to do that. Glad to have you here. Yeah.
Well, I could just talk. I'm
Yeah.
sorry.
Sorry, I was trying to, but it got broken up and then I missed part of it.
Yeah.
So.
Yeah. So I'm not working right now, but for 2 years I was working as a therapist, and there were clients who just regularly would say that they're going to kill. I mean, I had killed themselves, and one client who said it almost every session.
Yeah.
And
range of suicide, the range of suicidal behaviors, starting with the thoughts of suicide. And we're talking about adults specifically with this data. And by the way, the SPRC, the Suicide Prevention Resource Center, is a great resource for data. Many of these images actually exist in separate slide presentations. And I think, anything you can do to kind of learn something today and then go take that back and share with others is ideal. Stop by them and, don't reinvent the wheel. Use the materials they give to you to help your organizations, your colleagues, really improve their confidence as well. What we see here is the percentage or the raw number of individuals who report that they had seriously considered suicide in the past year. And that number is around 12 million. That's a lot. In fact, I would guess that many of you see that number and you're like, that's astronomical. 12 million adults admitted that they had a serious thought of suicide. This data, by the way, comes from SAMHSA's long-term ongoing study, the National Survey of Drug Use, National Drug Use Survey, and has a wealth of great data in it. Now, that constitutes 5% of the adult population, or another way to put it, 1 out of 20 adults that you run into in the course of any day will, in the next year, have a serious thought of suicide. So this is clearly a common experience. Now, I point out that it's common because many times when somebody has those suicidal thoughts, immediately it's like, I can't believe I had a suicidal thought. And especially for our clients who might be more anxiety prone, especially those who have some obsessive traits where they kind of get a thought in their head and then they just run full speed with it. Well, for those individuals, they will literally work themselves up and start to get much worse. So they'll be like, I had a thought about suicide. Why do they have a thought about suicide? Oh, that must mean I'm suicidal. Do I want to kill myself? I don't think I want to kill myself. Why am I thinking about killing myself all the time? Oh my gosh, I'm going to kill myself. And they're off to the races. And so one thing to always keep in mind is when you have those clients that are more prone to obsessive thinking and that, two things. The earlier you can give them some good cognitive behavioral, insights to help try to like arrest that process, the better, because you don't want that same type of thinking to get applied to a suicidal thought. Second thing, when we're making recommendations, mindfulness is a great tool for many people, but bear in mind there are some times when it's actually contraindicated. And somebody who might be more prone to that obsessive thinking or is experiencing a lot of intrusive thoughts, some mindfulness activities might actually make them more vulnerable to just be kind of bombarded with that. Some of our clients need to find ways to distract their mind, not entertain it. Like that's a few steps down the road. So keep that in mind as we just look at how common this is. Now, of that number, of that 12 million, only a fraction of them actually made a suicidal plan. And that plan could have ranged from just thinking like, oh, maybe I'll just jump off a building, to actually elaborately planning out how they were going to do it, making, like hoarding certain medications so they would accumulate enough to actually make a substantial attempt, or trying to create an opportunity to, have access to a firearm or something. And so that percentage relative to those who had a serious thought of suicide is about 29%. So 1 out of 3 people had a thought, went as far as making a plan, but even fewer actually then made an attempt. So only about 40% of those who made a plan, and only about 12% of those who had a thought. And of those who made an attempt, again, fortunately, the improvements in healthcare, the accessibility of resources to counteract that, especially what we've seen with like Narcan in recent years and widespread availability. What we see is that it constitutes, only about 3% of all attempts and 0.006% of those who had a thought. So one of the sources that can hopefully give you a little bit more confidence here is that suicidal thoughts are very common, but that translating into an actual suicide attempt is actually a very rare event. It's still too many, it's still too high, but it's still a more rare event. So when you're kind of faced with that sense of, oh my gosh, they have suicidal thoughts, they're going to do something, it's helpful to remind yourself that, okay, this is not a guarantee, this is not an automatic. In fact, it's still remarkably rare for that thought to go as far as an attempt. Now, when we kind of dig into this a little bit different, we've got some data from 2018 where the suicide numbers were about the same. And on this slide, we're starting with the reported number of suicide attempts that year, which was about 1.5 million. And of that, 49% of the attempts actually required some medical attention. So think about that. Half of the attempts were not serious enough to either warrant or prompt any type of, medical attention. One thing to keep in mind, especially in the days of having access to records electronically, we often put more reliance on the accuracy of what's in a client's chart versus what a client might report to us otherwise. And so I always make sure that even if it's been documented other places that the person, has never attempted, I always make sure to ask that question and try to do so at a point in our conversation where they feel more comfortable, because that's one that people very frequently minimize or they don't admit to because maybe a family member's in the room, they don't want to acknowledge it. But it's not uncommon to hear people say, yeah, I did. I took a bunch of pills one time. I fell asleep. I woke up and then I just kind of went on. Like never told anybody, never got any help. So that's out there. And so it's an important point to follow up on. 31% of those individuals who attempted required more serious medical attention. So they had to stay at least overnight for a suicide attempt. Most in like ingestions don't even require more than like a short stay, an OB stay, a 23-hour stay. So if they're staying longer than that, it was definitely more potentially life-threatening. In response to Essie's question, how would virtual assessment differ from therapy in person? Yeah. So I gotta tell you, I'm not a huge fan of the virtual assessments. I know that they're the only option, especially for those of you practicing in more rural areas, but it does really limit things a lot. One flip side of that is we have some evidence that people are more willing to be honest when there's this protective like barrier that they're talking to a screen as opposed to a person. And so we've seen this in other domains where people might be a bit more honest in those environments than they are when they're face to face with somebody. In terms of, do you ask different questions? No, but you might ask additional questions. If I'm thinking a person has just kind of been giving up and they're not functioning well, if I'm in person with them, I'm going to have one indicator that you can't have with at least current, electronic technology. I can smell them. I can get a sense of what their hygiene's really like. If they're neglecting their hygiene, I'm going to oftentimes know that by being in the same room with them. And as unpleasant as that might be, and as much as I might not miss that if I was doing, a video assessment, that is valuable information. So what I'd say is, for the virtual assessments, some of the questions you're going to have to be maybe a bit more concrete about, like when's the last time you took a shower, as opposed to, are you showering? That's maybe kind of a difference that you wouldn't have other data in form of what you can see or smell. Never see as easily, I should say. And again, when we look at suicide deaths, again, even breaking this down, 3% of attempts resulted in a death. Now, does this mean that, we shouldn't be super worried about ideations or about attempts? No, but it does mean that we don't have to, again, over respond. This image gives us a kind of overview of the people who reported having a serious thought of suicide. This is 2018 data from the National Survey of Drug Use and Health, again, that SAMHSA study. And what they found, similar to what the CDC found in the other data I showed you, was that, 10.7 million had the thoughts, and 7.2 million of them, or 67%, that's as far as it ever went. So for most people, when they have the thought, that really is as far as it's ever going to go. So when a client expresses that like they're having a suicidal thought, just engage in good clinical practice, right? Empathize before problem solving. Like, wow, I'm sorry to hear that. Things must have been really kind of bad for you to feel like that was an option, right? Express care, remind them that you do care. What's interesting, especially when we look at some newer initiatives like the Zero Suicide Initiative, which again essentially talks about like good training and preparation across organizations, doing good assessments like we're talking about today. And then the other piece is the follow-up piece. When individuals who had to go to an ER or made an attempt get a warm touch, a warm follow-up, a few weeks after they were seen, turns out it dramatically reduces the likelihood that they're going to make another attempt in the next 6 months. And I think that that's really a powerful insight, that something as little as a quick phone call to just be like, hey, we saw you a couple of weeks ago. I hope you're doing better. Have you been able to connect with services? Do you need any additional referrals or resources? Something that tiny can literally be, a make or break thing for people. That's how, lonely many people are, is that they don't even have something that basic. Now, I also want to draw your attention to this number over here in the lower right-hand corner, the 0.2 million who didn't make plans but attempted. These are the impulsive acts. And this is going to be, more heavily correlated with a younger age, the still 18, 19, 20s. We know that our brain doesn't fully form until we're in our mid-20s. And in fact, that last part of our brain to fully form controls little things like emotional regulation, judgment, impulse control, just minor details in life, right? That obviously things that are, pretty important to somebody managing something distressing. That 0.2 million, those are the ones where I don't know what could really be done in those situations. But I also point that out because the good news is that, again, is a very small fraction. Can we prevent every suicide? No, but I think we should try. What, if you ask me, is the percentage that I think really could not be prevented? That's what I point to. I point to the 0.2 million that like impulsively did something. But what I will say even about that 0.2 million is that, it's quite likely that they're part of the 50% who were intoxicated at the time they completed suicide, or the 20% who had opiates on board. So substance use disorder, we have a client, with a substance use disorder, regularly, assessing and looking at their overall risk profile for, assessing suicide is imperative. It has to happen, because even if they're not expressing that, their risk is very high because of that condition. And I agree, Michelle, like, the cookie cutter approach can be, again, there's a difference between using something as a guide and like to try to enhance our clinical efficiency and trying to fit our client into a mold or a model. And that's where really the problems start to come. So good insight, Michelle. Thank you. So just want to kind of quickly look at some of the stats a little bit more in depth before we get back to that kind of assessment piece. And again, this is such a short time. I hate to have to rush through this, but I'm glad we're at least starting this process and doing more with this. We looked earlier when we were talking about, the general statistics on suicide, that it is largely a phenomenon that we see with males. Males make up the overwhelming majority of deaths from suicide in this country. However, that's a number that we have started to see change a little bit. We know that race ethnicity also plays a significant role. And in terms of where do we see the most elevated risk, the American Indian, Alaskan Native population. And, one of the saddest conversations I, routinely have in my social work classes with students is trying to figure out just, could we even quantify what group we've screwed over the most? Like, I mean, we've done so many groups that comprise our wonderful country, like have experienced enormous marginalization. And I am a straight white cisgender male. I know it happens. Do I know it? Do I understand it? Have I experienced it? No, I don't get it. But I'll tell you, when I see this rate for American Indian, Alaskan Natives dwarfing most other race ethnicities in terms of like representation, it really draws, kind of a pretty clear line to all the structural pieces that need to be in place for suicide to happen. Those of you who have ever worked in child welfare are familiar with kind of the child welfare system. You know that when a child actually dies as a result of abuse or neglect, it was not a failure in any one particular area. It was usually like a systematic failure. Schools failed to follow up, and CPS failed to investigate. Other people failed to report. Like, there are so many avenues to prevent many of those cases, which makes them especially frustrating. When we look at suicide, what we know is that an individual risk factor doesn't have a lot of meaning, but when we start accumulating risk factors and put that in other contexts, like access to care, mistrust between healthcare providers and clients, we start to see how enormous those things get. When I worked in Arizona, The mobile crisis team I worked for had a contract for 2 of the reservations. And if you've ever been to Arizona, you know that there's not a lot going on when you're not in one of the cities, right? And if you've ever driven south from Phoenix to Tucson, you got to see a whole lot of practically nothing. What you might have seen was the testing ground for certain armaments. The Apache helicopters test their uranium depleted rounds in part of that area because nothing lives there, nothing grows there, nothing can grow there. So it's kind of land that, not a big deal. We throw away airplanes there. There's an airplane graveyard there. Because what else are you going to do with that land? Oh, I know. Let's give it as a replacement for Manhattan. Fair trade makes sense, right? But essentially, that's what happened. The reservations are so alienated, so isolated, and the resources that might be available to them aren't geographically proximal. Most of the providers that work with them are there for a year or two as a part of like a student loan repayment program, and then they vanish. And add to that, other struggles that increase the likelihood of substance use disorder, alcohol abuse being very high on many of the reservations. The corollary that has with trauma, especially sexual assault, astronomically high. Like it's all of these things coming together and doing so in the context of the 2 H's. And this is one of the most helpful things, hopefully, for you to take away. If you remember hopeless and helpless, you'll have a good framework for being able to articulate when a person actually needs, our immediate assistance. When they don't have any belief that things can get better, and when they don't feel like anything they do could change their situation. Those 2 ingredients, we gotta step in. That's probably somebody that we're gonna have to look at a higher level of care for. Now, that's followed by, whites, and then the overall population is that yellow line. Now look at what we see, down here, and there's been a little bit of a juxtaposition of, the rates relative to other groups. Asian Pacific Islanders, Hispanic, and Black. Too often in our approach to understanding health outcomes, we use, the assumption that access to resources, healthcare, et cetera, are all better if you're white than if you're non-white, and that's true. But when we look at many health outcomes, there's not the relationship we expect. We see that with infant maternal mortality, that it's not quite as clear. There's always been what we've called the Hispanic paradox, that they have better infant maternal mortality outcomes than the rest of the population, despite being more likely to live in poverty. There might be something about the collective experiences of facing so many different challenges, the trauma of, racism, the trauma of poverty, all these things that do provide some sense of solidarity, that provides some sense of, inoculation against distress. But instead of, just asking like, okay, so we see this racial, disparity in outcomes, I think we need to go the next step and say, what can we be learning from these communities of color to better help, the rest of us find ways to become more resilient, to like protect ourselves from suicide, because they're doing something that we really need more of. And unfortunately, that's not a conversation that's happening. And it's one that maybe collectively we can kind of move along a bit. And again, what we see, even looking at adolescents, is we see, a very similar kind of, presentation. American Indian, Alaskan Natives are still much more at risk than, their corollary counterparts. I talked about location and gender a little bit earlier, and I said, sometimes where you are has more to do with suicide risk than anything else. What you're looking at in this map is suicide rates on a county level. The darker blue a county is, the higher the suicide rate. Do you notice any trends when you look at this map about suicide and location?
There's more suicide where it's more sparsely populated.
You bet. And when we look at kind of the rural, rural Appalachia in the center of the country, when we look at, the northeastern part of the Lower Peninsula or the entire Upper Peninsula of Michigan. I actually come from the upper part of the Lower Peninsula. If I want to go to a therapist in high school, which dear God, I should have, I would have had to drive 45 minutes to Traverse City to get to one. Well, that's a challenge, right? I do some consulting with some of the community mental health groups in the northern part of the state. And they've got 6 counties. They've got like 1 million square miles to try to provide services for. Like geographically, they're dealing with all the same challenges we are in Southeast Michigan in terms of a lack of prescribers, just a shortage of personnel overall. But then they add to that this kind of natural isolation that people have. And it turns out humans don't do great in isolation. So rural areas, not only are people more likely to have some challenges to even, being around each other, but there's, also that corollary where why do males end up completing suicide more often? Well, one of the primary explanations is the use of more lethal means, specifically firearms. And in rural areas, firearms are, part of life. Like that's like in 5th grade, I, with everybody else in my class, took hunter safety because you did. We got November 15th, the opening day of deer season, off every year because nobody was going to come to school anyway. I mean, like there's that rural culture and firearms are ever present. Combine that with socialization that says men have to, be stoic and, a lack of providers, lack of resources. And you've got, again, all those structural things that in many ways we see exemplified by Native American reservations. You've got all those ingredients at play. This is, again, a more detailed view of that map, but specifically looking at Michigan. And again, you can see the more rural it is, the more is going on here. Now, how does that translate more internationally? There seems to be something to that. The US does have a very high rate. And I'm sorry, Bob, I'm not sure why you can't see the slides right now. Can other people see the slides or did I do something wrong? Okay.
Oh, we can see the skies, Dr. Smith. It's on age standardized suicide rates.
Yes.
Yep.
And okay, perfect.
Mhm.
Part of what we see here, and keeping in mind globally, there's still been a lot of challenges to collecting some of this data, is that some of the more like rural countries like Russia, more land mass than Pluto. I don't know if we're calling it the planet again or whatever, but it's larger than that. Like we see certain trends kind of continue on as well, but kind of bringing it back to more of like a local focus. The other thing that seems to be incredibly important is the effect of age. And age is one of those big, factors for 2 reasons. One, we definitely see that there's, a pretty substantial difference in your suicide risk depending on the age group you fall into. And then the question is, well, what explains that difference? Now, I want to start by looking at the period of 2010 to 2019. And what we see in, when we look at that kind of time period is that 45 to 64-year-olds maintained, the highest level the entire time, and 15 to 24-year-olds, the lowest level the entire time. The 65 and older and 25 to 44, they kind of swap places throughout during this period. Now, when we think about things like the Great Recession, that was starting to kick off, a little before the 2010 mark, but by 2012, that's where we were really starting to see the effects filter down, people losing homes, displacement and that. So it's not a big surprise we start to see the adolescent rate rise at that point because their environment started to experience much more disruption. And then unfortunately, divorce became more common. So fractured families, compromised support systems, and a lot of just, dominoes started to fall. But what happens when we back up to 2000? When we started this millennium, the most at-risk population wasn't the 45 to 64-year-olds. It was the 65 and older. And at the beginning of my career, you worried most about older adults with any type of pain or debilitating illness. That was who was in the majority of suicides. And what we saw was at certain key points, there was a spike. 2005, when the economy started to first hit the Rust Belt hard and then like spread out from there. Look at what happened with that 45 to 60-year-old point. Now, this is a pretty obvious trend. When did it get addressed? I'll let you know when it does. What makes it hard to intervene with people in that age group, 45 to 64? Why is that a struggle?
Set in their ways.
Okay,
Stubborn.
so they're a bit more set in their ways. Another thing that happens is they are kind of in their prime earning years. They're very career kind of focused and also consumed by other things like their children and that. And so as they start to make those things like kind of the primary parts of their life, what happens if that's disrupted? Like if you have a career and that's what gives you your sense of purpose and importance and value, and now you lose that. That's a blow. That's huge. So to say that like, losing a job is a risk factor, well, yes, but much more so at certain ages than it is at others. And much more so for, depending on gender as well. So these, again, there's this interaction. Now I want to kind of jump down to, some other information such as, historically we've talked about the relationship between depression and suicide. And while it's true that overall, one of the best, predictors of suicide is major depressive disorder, we know that it's estimated about 50% of people with major depressive disorder at some point in their life will make a suicide attempt. And, some research suggests as many as 50% of those will complete suicide at some point. That would give major depressive disorder a fatality rate of 20%, which is higher than most cancers now. When we talk about like survival rates. So just to kind of put in the perspective, that's a big deal. Now, while we saw, adolescent suicide kind of skyrocketing, what we didn't see? We didn't see rates of reported depression going up. Now, this is one of those trends that kind of defies the norm. And what it does is hopefully highlight the fact that, there are certain X factors depending on somebody's age. So for 45 to 64, some of those X factors are like the importance of their career, what's being compromised. For adolescents, it's that impulsivity, it's their developmental level, it's their lack of experience. The longer you live, the more you figure out you can get through, right? That's the consolation of living long enough and going through enough hardships, is that along the way, you learn that you can get through it. If you're 13, 14 and are facing something that's frustrating, you don't have a big window of time to reflect on. And it's hard, to have an adult say, 10 years from now, you won't even think about this. If you're 13, you can't imagine 10 years. You only have a working memory of maybe, 8 of your 13 years. So to give you a timeline like 10 years, that's challenging. Again, when we're working with adolescents, part of what we want to do is really keep it more narrowly focused on how are we going to do better until we get to the weekend. Let's keep looking forward, take this a bit more into like baby steps. Now, does that correlate to resilience? To some degree, yes. Let me give you an example, and this is Terrell's question. I had a young lady when I was doing my school social work internship in a suburban, very affluent Chicago school. And she came into my office one morning hysterical, in tears, sobbing, and I was preparing myself for her family having been murdered, something just horrible. And what she ultimately revealed was that she was supposed to be able to take her parents' new Lexus out with her friends that weekend, but they changed their mind and she had to take her sister's Camry to go out with her friends. And that's what had her in crisis, crying hysterically in my office on Monday morning. And being a new social worker, I made it clear I didn't have time for that nonsense and sent her to class. Now, a little bit older, a little bit wiser, what I realized is that was the hardest thing that young lady had ever faced in her life. And that was not a gift to her. She wasn't, her parents had managed to protect her from so much that a little minor setback took her out. How many times do I hear an adolescent have their cell phone taken away and they're like, I just want to kill myself? And my first thought is, kid, life's gonna kick your ass way more than that. I don't know what to tell you. Like it's like this is a low key problem if ever there was one. So let me just kind of put this in context. But again, we have to kind of step away from ourselves and not have that reaction. Remember, you only have the type of resilience, you only have the hardiness that you've been offered. And, you know, is there better ways to maybe help, you know, children and adolescents experience problems safely and, you know, guide them through that? Potentially. And, you know, that's a separate conversation. But absolutely, if you have not been exposed to much, you haven't gained that sense of confidence that you can actually get through things. And that's part of what goes into resilience. Now, even though adolescent suicide rates have increased, and especially in the last 7 years or so, if we go all the way back to 1991, what we see with adolescents is that far fewer of them are saying that they're thinking about suicide. And this is why, again, for adolescents, we have to always keep in mind that X factor of impulsivity. So if we are working with an adolescent client and we're concerned at all about like possible suicide, we want to really have a tough conversation with the parents that we need to make this house as safe as possible. We want to remove all of that immediate access to something that could do harm. And here's something that I've learned that was never on my radar before a few years ago, but it started to become a trend. And I talk to parents who have an adolescent that's struggling and say, hey, have you made the house safer? They'll often say yes, that we've locked up or don't have any guns. We've put a lot of the knives and sharps away or locked in the cupboard. All the prescription medication is put away. I always ask, Tylenol, aspirin, are those around? Are they over the counter? I would just get all of them out of the equation. You also need to ask, what about the pet's meds? So many pets are prescribed medications, and many times, you know, the same medications a human would take for a similar condition. And many of the medications still prescribed for pets are not prescribed to, you know, people anymore because they're too dangerous. And I've had a lot of clients I've seen at the hospital who took an overdose of their pet's medication, but people didn't even consider that. They're like, well, that's pets, that's not humans. So always make sure to ask that question. And that's another good question to Terrell about the relationship between, you know, environmental factors, tech savviness. One thing we know about screen time, as much as we haven't seen consistent results from the like harm that it may or may not cause, we have seen a decline in attention span and an increase in like relative impulsivity. So there might be something to the fact that technology has given us more immediate gratification, and that might translate for adolescents into like almost an incentivizing or encouraging of like impulsive behaviors. Add to that we just had some research come out earlier this year that found despite adolescents feeling like they had more ways to talk to or connect or interact with their peers, they were reporting all-time high levels of loneliness. So again, we're talking about the significance of that isolation, that loneliness. There is a difference between, you know, texting with your friends and actually having somebody's physical presence near you. We don't fully understand it yet, but that's definitely there. We talked about means, and again, I encourage you to kind of look through the stuff. I want to kind of move forward now and talk a little bit more about the assessment in our remaining all too short amount of time. But what I do want to kind of draw your attention to when you go back through and look at this, the percentage of females who now are using firearms for their suicide is getting higher. And this is not the type of gender equity I think any of us was hoping to see here. Historically, we've always talked about the fact that males complete suicide far more often than females, but females historically have attempted suicide at a rate about 6 times higher than that of males. What happens if they start using firearms at a comparable level of males? We're going to see a complete flip in terms of the overall like risk associated, with sex, and we're actually going to see the numbers of suicides skyrocket. Like that's the nightmare scenario. So that's worth just maintaining kind of an eye on. I also thought I would show you this little map real quickly. This is drug overdoses on the right-hand side and suicide on the left-hand side. So we can kind of see that there's an alarming amount of overlap here. And I actually shared a similar slide doing a training before, and they're like, "Are you trying to make a red state, blue state argument?" And I'm like, no, when it comes to suicide, every state sucks. So don't worry. Like this can be an apolitical thing. Like, no, really, nobody's got their act together. Don't get hung up on that. So getting back to the assessment and what we want to be doing. We want to really, again, that psychiatric examination, that's the piece you're most familiar with, right? That's the what's going on for the client, what's happening now, what are you experiencing in your life. The risk factor piece, like let's kind of look through what we know to be some of the biggest risk factors and how we might want to kind of incorporate that consideration. So we do know that, in terms of overall, that 45 to 64 is where we're seeing, the highest amount of suicides overall. But 18 to 24-year-olds, it is the third leading cause of death. And in terms of interventions, it's much easier to target that age group for interventions. It's a lot more clear cut for many of the reasons we talked about, some of the barriers. Also keep in mind that although we kind of put that 45 to 64 window out there, we do tend to see much more action in that, like the 55 or so points. And this starts to correlate with a variety of other factors, such as becoming empty nesters. This is the point where divorce rates are relatively stable. If you make it past like the 1, 3, 5, 7, and 9 year marks, now you get to the 20, 25, 30 year marks. The kids leave, you look at this person you've been married to and you're like, "Oh, I remember you. We met a long time ago and just haven't, bothered to maybe talk to each other too much since we raised children." So there's some unique factors that kind of creep up there. Sexual orientation, gender identity issues. This is usually considered to be the #1 predictor of suicide for the 18 to 24-year-old age group. It actually, there's more and more evidence to suggest as young as 15, this is the #1 predictor. Here's a fun fact. Anybody want to take a guess at what the #1 predictor of homelessness for the same age group is? If you guess sexual orientation, gender identity issues, you are correct. What's the common overlap there? Family. If your family does not accept you, if your family rejects you, your risk for suicide, your risk for homelessness or housing instability, all those factors just get magnified so much. And I've unfortunately heard it way too many times. Like I've literally had suicidal adolescents in my ER and had a dad say, "Well, if he's gay, I'd rather him be dead than be gay." And I have no words for that. I don't know, but that's definitely, a factor that we want to be able to address. This is older information, but just it's a good reminder. The contagion effect of suicide is a big deal. We know that historically, when you lived near, especially in the college dorm, somebody who completed suicide, if you had been considering suicide, it made the idea more acceptable, especially if people were celebrated or revered. What we've been seeing in recent years is that social media has an effect of giving people the impression that they're closer and more connected to people. So when Avicii completed suicide, when other celebrities have taken their own life, many people connect with them in the same way. And we still tend to kind of idolize and celebrate like Anthony Bourdain, Kate Spade, other people when they're famous and complete suicide. We treat it like any other death, and that can actually encourage or even incentivize people who are having suicidal thoughts. So I think it's always a good, as we're working with our clients, we want to pay attention to whether or not, we've heard about suicides, maybe, in their area, their school, a celebrity suicide. We want to kind of touch base, want to check in on that. Additionally, if somebody is experiencing psychotic symptoms, especially if they don't have insight to their symptoms. So if they kind of at baseline are always hearing, voices, they might recognize that, and that might not be a red flag. But if they don't, their risk to do something, especially unintentionally, is very high. And there's almost, no circumstance where, at the very least, somebody who's acutely psychotic doesn't need to at least go to the ER. Sometimes we can do some medication stuff just in the ER that will kind of put things back on the right track. But that's one of those situations that becomes a little bit easier. It's like, yeah, we want to get on that. We talked about the history of attempted suicide and substance use problem before, but keep in mind, when somebody's facing a serious health problem, financial problem, or legal problem, anything that starts to limit their options or alter their future, the way we understand it is it's essentially taking away their sense of control and power about their future, and leaves them feeling that hopelessness and helplessness. So those are definitely, big things that we want to kind of focus on and address. Mental illness, there haven't been many studies. In fact, the best one is now quite old. It goes back to 1993. But a psychological autopsy is similar to a forensic autopsy, except that it involves reviewing records and psychiatric history. And what appeared to be, overwhelmingly, true is that only 12% of individuals who completed suicide just had one axis one. Those of you remember the multi-axial system. They had just one mental health diagnosis and no comorbidity, no co-occurring substance use disorder, no health problem. That was good news. If you're dealing with a mental illness, is that elevate your risk for suicide? Somewhat, but it gets much worse when we see things combined. The presence of anxiety in of itself is, not considered to be a primary risk factor for suicide. But if you have depression and anxiety, and quite frankly, most of those symptoms overlap to the point that you could flip a coin and decide what you're going to label it as. But that combination does have a significantly elevated suicide risk. So, do your best when you're talking about somebody's symptoms to really try to figure out, are we dealing with depression and anxiety simultaneously? Because that's going to be one of your red flags of, we got to do more. We gotta up the intention. What's protective? So religious beliefs that deter, and that's not universally true. I've had clients who were Catholic and believed very much that suicide was a mortal sin, and I took the opportunity to remind them of that, because I'm not trying to misuse their religious beliefs. I'm trying to save their life. I'm trying to keep them oriented on things. And if that's what's going to keep them from completing suicide, you better believe that we want to break that out. Good coping skills, and we know that, right? Our clients will never have enough coping skills. We don't have enough coping skills, right? Like the variety of, types of wine in a refrigerator do not constitute multiple different, coping skills. So we want to always be increasing it. We want to be increasing it for our clients. Their tolerance of distress, of psychological pain, as we talked about. That's a big fact. How about this one? Extroversion. And I get that some of you have to jump off, and I'm going to wrap up, but if you have to leave, thanks for hanging out, albeit virtually.
We are
Extroversion
recording this session, Dr. Smith, so you can keep talking even if it's just me and you. And participants can watch the
I
recording
shouldn't
later.
have said that. Now everybody's in trouble. All right. The extroversion piece is one of those factors that we've observed actually for about 40 years. It's a simpler explanation than it seems. Extroverts, the reason they're protected more in terms of suicide risk is that an extrovert gets energized by being around other people. And that means that when they stop spending time with other people, it's more noticeable. An introvert who needs to kind of step away and recharge, fewer people notice they're not around maybe as much as they used to be. And so we don't have kind of that early insight to something might be going wrong. That's why it's a problem. Pregnancy and having children at home, generally speaking, is protective with the exception of postpartum depression or psychosis. Or teen pregnancy, we do see that actually as having a suicide risk increase there. When there are severe economic hardships, a pregnancy can actually increase suicide risk. So again, it's generally protective, but there are some of those circumstances. So again, we don't need a matrix necessarily to say like, oh, well, they're pregnant, so we'll put that in the risk column. We want to say, how are you doing with your pregnancy? Are you, feeling optimistic about things? Are you excited about things? Are you worrying about things? We want to do what we actually intuitively do, very, very well. Oh, and Holly, in terms of receiving CUs, yeah, Chantalia answered that. You'll get a follow-up email. I think there's a 10-question post-test that shouldn't be too taxing for anybody, and then you'll have CUs to prove you are now a leading expert on this topic. So you're in good shape. So breaking down that assessment, the ideations, those frequent thoughts, what we want to know is, are these intrusive thoughts and are they ego dystonic or not? And ego dystonic is just a fancy way of saying, does the person find them unacceptable or unpleasant? If they do, that's a much lower risk than if they are comforted by them. If they're holding out suicide, kind of like I was talking to Thea about during our break, they're holding out suicide as kind of their strategy for managing things if it gets too tough. That's not something I'm ever going to feel entirely comfortable not having way more things in place, right? Like that's somebody I would worry that they have a bad weekend and I don't know what would happen to them. Some people are going to be suicidal at baseline. So if you know your client, you'll be able to kind of distinguish between when this is atypical of them or not. And the best indicator will be what areas of impairment are they experiencing that normally aren't a problem. Now, when we're assessing anytime there's been a threat, which only refers to the expression of suicidal thoughts and not just in words. It's not like if you don't do this, I'm going to kill myself. It's the term threat here purely means that it's a verbalized threat. So we want to consider that. And I've got a couple of tips for you. My primary tip here, if you get the knowledge, especially secondhand, that somebody sent a text or posted something on social media or made a statement, if you ask your client like, hey, did you say this? Very often they'll say no. And now you just got outsmarted, right? You're okay, well, now where do I go? Instead, you need to approach it with a presumptive positive. Say, so I heard about the text, I heard about the post. Why did you, what was going on that made you maybe feel like that and post that information? You start with the presumptive and it isn't true, they'll be like, yeah, I don't know why people think that. I didn't do that. Great, you clear that up. But more often than not, if it is true and you start with that presumption of positive it actually happening, they're gonna be more likely to explain why they did it. And now you've got that kind of firsthand information that if you have to pursue maybe a petition to try to involuntarily hospitalize somebody, you've got that direct firsthand information you need for it. And you also now have an opportunity to get in and explore the issue that might become the antecedent for some type of suicidal behavior. What was going on? Why did you kind of reach out in that way? And this isn't just true when somebody uses words. This is going to be kind of a disturbing image, but this was posted to social media and we kind of have to be familiar with something like this. Sorry, this image. Now, you don't have to post any words, but if I see an image like this posted, you're going to have a real hard time convincing me that you were not only having suicidal thoughts, but you had a plan and, you appear to have some intent, especially with your finger being on the trigger there. One thing that I often hear, from students in an internship or from former students who are talking to me or other people I meet is they feel like if somebody's not clear enough about their suicidal thoughts, that they don't have anything to go on. And what I would say is very rarely do people use really concrete terminology. It's important that we do, but don't necessarily expect that they will. So expressing it like this is actually far more common. When somebody is having suicidal thoughts, often they'll say like, they'll use almost onomatopoetic kind of expressions. They'll be like, I just feel like I wanna, and so we have to learn how to document that. Be like, client, expressed a sigh and lifted their hands and eyes towards the sky to give me the impression they were thinking about death. And we follow it up. When I started my career, we used to ask the question, have you been thinking about hurting yourself? And the problem is if that's the question we're asking, we're not assessing suicide, especially with, millennials, Gen Y. If you ask, are you thinking of hurting yourself? They exclusively hear that as self-injury, as cutting. We need to ask the blunt question, are you thinking of killing yourself? Do you wish you were dead? And I'll tell you, there is no more like kind of invasive question. I never feel 100% like comfortable when I'm asking that. I always feel like I'm violating somebody because that is such a direct question. And it is the psychological equivalent of stripping somebody naked. Like you are really getting in there. And because it feels so like awkward and uncomfortable, it's one of the most common mistakes people make when they're assessing suicide. They don't directly ask that. So either they misinterpret what the client means by hurt themselves, or they don't ask the question to get the kind of clarity they need to make the correct decision. So as unpleasant as it is, ask it. Tara, thanks for joining. Good to see you as well. As far as slides, I've only got a couple of left. So we're almost done. Plan, when we're looking at their plan, not having a plan is obviously a positive sign. Don't try to elicit a plan from people. This happens very often. I see this especially with like ER nurses and even ER physicians sometimes. Will be like, so have you thought about how you would kill yourself? And they'll say no. And they'll be like, well, if you were gonna, how might you do it? I don't know, jump off a bridge. Okay. And then they put down that they have planned to jump off a bridge. I'm like, they don't need your help with that. Come on. Like, do you have a plan? No. Okay. Let's not, put them in a brainstorming session about this. Lack of a plan means that they had the thought and they don't want to have the thought. That's a good thing. But when they do have a plan, we want to assess two things. Do they have access to the means to carry it out? And what's the lethality of it? Now, not their perception of lethality, but like actual perception of lethality. So if they're saying, well, my plan is to overdose on gummy vitamins and I have a Costco-sized jar at home, that's still not going to get the job done, but that's a serious risk. Why? Because they believe it will kill them. And what it's saying is if they take the gummy vitamins and 2 days later, they're still fine, they're probably going to progress and try something else. So we still want to take that really seriously. Now, at the same time, I had a client that I saw probably once a month when I was doing mobile crisis teams in Arizona. He had the same plan every time. He was going to blow himself up with a bazooka. And because it was Arizona, I had to check every time, like, so any luck getting that bazooka? Yeah, no. But that was his plan. I'm like, if you can't get a bazooka, are you going to try to do something else to kill yourself? No, I want to make sure like I do it and don't feel pain. So it's got to be with that. And I'm like, all right, well, I'll see you next month, buddy. And at the same time, cross my fingers that he doesn't come across the bazooka. But not having access to the means, like restricting that does take away things, because most people, when they're suicidal and they make a plan, that plan is to do something that's painless. And they get pretty wedded to an idea. They're like, I want to do it this way because I believe it will be painless. They're in pain. They don't want to experience more pain. Talked about intent. We have to have that, and you have to document that. What do you want to happen? I want to die. I want the pain to end. So when you say you want the pain to end, do you think the only way that pain can end is if you kill yourself? Yeah. Okay. So you want to die to end the pain. I want to be real clear about that, because that's, of all these specific suicidal inquiry issues, intent has the most, like reliable, like correlation with actual like completed suicides. And we also talked about the future orientation piece that we want to be looking. I always start distal and I'm like, so, hey, have you thought about what you might do, for the holidays this winter? And then I start moving back. And when people haven't given any thought to even like later that day, that weekend, this is somebody who clearly is incapable or doesn't feel like there's any reason to think about something that far away. And that's somebody who's going to require much more immediate intervention. And so then along with, this broader, suicide assessment, support system and life stressors tend to be the more proximal determinants of those impulsive suicide attempts, as well as just a sense of feeling like they have other options. If somebody does have a good support system and you can work, especially with that support system, to get them to, understand the difference between having a suicidal thought and wanting to kill yourself in that moment, that often becomes enormously protective of the client. Not having a support system, that's all they are, is one bad experience away from having nothing. And here again, we don't have anybody that's kind of helping us to monitor them, to check on them. If you live in an area that maybe has like 28-day crisis services, that can be something you can potentially take advantage of depending on their insurance status, unfortunately, but you might have other resources. But in more, suburban, rural areas, you don't even have those resources available. If you're it for a client, if you're their only support system, that's already going to put them at a much more elevated risk of suicide. And then certain life stressors, we know, like loss in general, tends to kind of create a situation that exceeds most people's capacity to cope. When these two things combine, high like life stressors along with low supports, that person is as vulnerable as they're going to be. They're burning through their capacity to cope at a rate that's not sustainable, and they're going to need some help. Oftentimes for situations like this, if they're not acutely suicidal, I'm still going to say, I don't like where you're heading. And I like partial hospitalization situations like this, when I'm like, you've got some depression going on, you don't have any support systems, your relationship's on shaky ground. This could real quickly get out of control. I want to either, start doing 2 sessions a week, maybe even 3 sessions a week, depending on how your practice works and billing, etc. Or this is where a day hospital program might be really appropriate, because it's going to give them kind of additional supports, something else to do, especially if there's otherwise downtime, more eyes on the person, maybe a medication consult, an adjustment. Like there's more resources, and it's far better to kind of early intervene here with more of a middle moderate level of care than to wait until now we're like having to go all the way up to maybe an inpatient stay. And then again, when do we know we have to go to that point? And this is kind of where we're going to end today. If they're having command hallucinations, they're hearing voices telling them to harm themselves or somebody else, they're seeing a person direct them to do something, that they have to go into the hospital. A specific plan that's highly lethal, and they have access to the means to carry it out. Now, somebody asked a question earlier about suffocation strangulation. That's still one of the primary preferred methods for women. Males utilize it too. I've seen a resurgence in attempts to complete suicide by using carbon monoxide poisoning. But fortunately, the EPA regulations around modern cars have actually made that really, really difficult to actually build up a toxic enough level of carbon monoxide. And many people have actually, like I sat in my car with a garden hose pumping into my car for 6 hours and finally got so annoyed that I just came to the hospital. I'm like, all right, thank God you own a Prius, I guess. Like that's, like, okay, so there's save the earth and a life right there directly. Their inability to contract for safety. Now, what I want to say about this is I'm not a big believer in like written contracts, and the research is pretty clear that like contracting for safety is not a valuable thing. What I mean by this is that you ask them, like, do you think that as long as things are going the way they are now, that you'll be able to be safe and, you know, do the things you need to do to take care of yourself, you know, through the weekend for the next couple of days. And if they're like, I can't even think that far. I don't know what I'll do. If they're not certain, then that's going to be a pretty clear indicator that, yeah, they've got to go in, especially because life is not predictable and they'll be too vulnerable. The presence of a note, and here's the hard thing with that. We can do another presentation sometime, Chantalia, and I'll just show you, I've got dozens of examples of real suicide notes, and I'd love to kind of take you through and show you, here's a suicide note that was associated with somebody who made a serious attempt, and here's a suicide note that was more of a gesture or cry for help type of thing. But if somebody writes a note, the reason why that's going to pretty much guarantee that you need to seek a higher level of care is because there's no way you'll ever be able to defend your actions if they actually do something. I've unfortunately put people in inpatient settings that I did not think really wanted to die, but they wrote a note and made it very clear they wrote a note. And so nobody was willing to take the risk to say like, we think that this is attention seeking or parasuicidal behavior. It's just, it's too risky, unfortunately. A note very often though does connote somebody who now has kind of thought about it and arrived at a decision. A note is usually that last step when they've like decided, okay, I've got a plan and it's time, I need to do this. And I want certain people to know why I'm doing it. So that is more often than not why there's a note and why they need hospitalization. And like I had mentioned before with that adolescent, their affairs in order. They've gone as far as making sure that everything's labeled so people won't fight over things after they're gone. I've gone over time. I guess you could either frame that as you got more than you bargained for from this, or that I got too sidetracked talking about other things and didn't use your time appropriately. If you're in the latter category, my bad. If you're in the former category, you're welcome. But I'm good with sitting here for a little while longer.